Hi everyone, and welcome back to our case study webinar, where we turn theory into practice and science into knowledge. Today, our speaker, Carlos Juaristi, medical doctor and clinical genetic liaison at Centogene, will talk about the clinical and molecular approach to inborn errors of metabolism. During the case study, he will discuss the following topics: Inborn Errors of Metabolism Overview, CentoMetabolic and CentoIEM panel insights, case studies showing different diagnostic scenarios. If you have any question, please enter them into the Q&A chat and we will refer back to them at the end of the presentation. It promises to be a very interesting webinar, so let us begin. Carlos, the floor is yours.
Thank you for the introduction, Elizabeth, and hi to everyone. So through the next slides, we'll have an overview about Centogene, and then we will get down to the topic of inherited metabolic disorders. We'll discuss some of them characteristics, how they are classified and how do they manifest. And also we will review two solutions bring out by Centogene, which are CentoMetabolic and CentoIEM. And finally, we will share some cases that we have faced here at Centogene. Now, just to take the opportunity to talk about rare diseases, we have that about 350 million worldwide are suffering from one of these disorders. And if we take into consideration that the journey for the diagnosis of these disorders had been frequently referred as a diagnostic odyssey, then and that the evaluation of these patients takes in average passing through 8 different physicians or suffering from the misdiagnosis of 2-3 different diagnoses before reaching to the definitive one, and that this whole process takes about 8 years in total, which also can be understood that these are 8 years of missed opportunity for an adequate treatment. Then when we can dimension the importance of this diagnostic odyssey, and this is something that Centogene is taking to great consideration, and they have the goal to provide precise medical diagnosis at the earliest possible moment and to transform the genetic data into medical decisions. In this slide, you have a summary about the different products offered by Centogene that are available for the diagnosis. And I would like to take a quick view about CentoCart, which is a very smart solution because it's very easy to prepare and it's very easy to manage and to transport, and makes available this science and technology to every place in the world. And you can perform from a single variant determination to the sequence of a complete exome or a complete genome, and also biochemical testing may be performed in this, from this sample, which will be especially relevant for today's topic. Now, about inherited metabolic disorders, they are a very heterogeneous group of disorders that are caused by a defect in a metabolic pathway. Now that next generation sequencing have been introduced, new ones have been discovered on a regular basis, and now there are more than 1,000 knowns. And it's estimated that about 1 of each 800 births will suffer from one of these disorders. They are commonly inherited as autosomal recessive manner or X-linked, but other patterns of inheritance are also possible. And they may manifest at any age. There are some that will be evident since prenatal stages of life, and some others won't be reachable or detectable until adult ages. And most of these disorders have serious consequences and may prevent permanent handicap or drive to early death. So when we know that many of these have efficient treatments and that the early intervention may prevent these complications, then we cannot take the chance to miss them on the diagnosis. Now, they gave rise to symptoms by some common mechanisms. If you look at the right of your screen, you will see a very simplified diagram of a metabolic pathway in which an initial substance goes through a series of processes mediated by different enzymes in order to get a final product that may be the synthesis of an important molecule for other processes, or the production of energy, or maybe the degradation of certain molecule that needs to be eliminated. So in a metabolic disorder, we have that one of these enzymes is not working properly, so that the substance that should be processed by this enzyme starts to accumulate, and this may have a toxic effect in itself, or that this accumulated substance will take an alternative pathway that in normal conditions won't be so active, and this may cause the incrementation also of an alternative substrate, and this may also have some clinical consequences. And we can also have that the final product that won't be available at the needed quantities will also cause some of these clinical manifestations. And naturally, all these disorders are grouped depending of the metabolic pathway to which the enzyme, the affected enzyme belongs. And we can even classify them even further. And this is a very practical classification that may help us to start even planning a diagnostic and therapeutic approach in which the metabolic pathways are divided in 3 big groups. And we have intermediary metabolism disorders, energy metabolism disorders, and those disorders of the management of complex molecules. Now, for intermediary metabolism disorders, the symptoms arise from the accumulation of toxic compounds, and they usually arise from an otherwise healthy baby with an initial free symptom interval, and they follow by deterioration that may be caused or triggered by some high metabolic states like fasting or an intercurrent illness, or maybe the food consumption. And well, fortunately, most of them are treatable. This is the most numerous group of disorders, accounting for about 70% of the total cases. And here we have amino acidopathies, organic acidurias, urea cycle defects, some sugar intolerances, and other metabolic pathways related with the processing of small molecules. And some treatments that have been successfully implemented are mainly the dietary interventions, trying to avoid this substance that will cause the production of the toxic metabolite. Also, some supplementation with different cofactors may help to enhance the metabolic activity. And also some drugs that will ease the elimination of the toxic metabolite may be implemented, or maybe will limit the absorption. And for the energy metabolism disorders, the symptoms rise from the deficiency in the energy production. And here the clinical picture may be triggered by acatabolic states like those after fasting, and some of them are treatable. And if we consider that mitochondria are the main organelle involved in the energy production, and that fatty acids and carbohydrates are main sources of energy from the diet, then we can understand why those disorders affecting the mitochondria or fatty acid oxidation or carbohydrates management are classified here. Now, they also account for about 15% of the total cases, and some of them may be treated, including the dietary intervention, and mainly trying to avoid fasting or to adjust some micronutrients in order to facilitate alternative sources of energy. And also they may benefit from some cofactor supplementation. And finally, we have these complex molecule disorders, which are the symptoms are permanent, progressive, and independent of the catabolic anabolic states or from food consumption. And they are usually followed by some multisystemic involvement. So probably these are the ones that have the most variety of different clinical symptoms that we might find in them. And here we can encounter lysosomal storage disorders or peroxisomal disorders. And recently, some therapies have been implemented to some of these disorders, like the enzymatic replacement therapy that is now available for some lysosomal storage disorders. Also, there is therapies for the reduction of substrate, or the hematopoietic stem cell transplantation have also been implemented with some success. And depending at the age to which the symptoms arise, we may expect to have different presentations. Those disorders that arise during the newborn period will give rise to non-specific symptoms related with a neurologic deterioration, like respiratory distress, hypotonia, vomiting, lethargy, seizures, or coma. Frequently, they start after a symptom-free period, and some, especially amino acidopathies or organic acidurias, may give rise to special characteristic odors that may give us some additional clues for the diagnosis. And about 50% of the inherited metabolic disorders won't present in such early stages of life, but rather in late childhood or in the adult age. And here we can have some acute presentations in form of metabolic attacks, or some chronic presentations also in form of maybe developmental delay or organ dysfunction. And in adult presentations, psychiatric disorders have been frequently reported. Now, this list does exemplify some of these characteristic smells that are reported. Maybe the most famous one is the maple syrup smell in the maple syrup urine disease. And well, there are some laboratory testings that will help us to approach these disorders and to try to narrow the diagnostic suspicious. If you see there at the right of the screen, there is the list of some investigations that are recommended whenever we start the approach for these disorders. And we may have some common findings like hypoketosis, hypoglycemia, metabolic acidosis, hyperammonemia, or lactic acidosis, etc. So ammonium is a neurotoxic product that is derived by the deamination of amino acids, and it should be tested in any patient to which we have an impaired consciousness or encephalopathy. There are many non-metabolic causes of hyperammonemia, and also we can face some false elevations due to improper management of the samples. So whenever we want to approach the determination of ammonium, the sample should be taken from free flow without the use of tourniquet, and also should be placed immediately on ice and transferred to the laboratory in order to determine the ammonia levels. And urea cycle is in charge of transforming ammonium into urea, which will later be eliminated through urine. So we should expect that any disorder involving one of these enzymes will present with very high levels of ammonium. Also, urea cycle defects, we will often find them followed by respiratory alkalosis, which may help to differentiate from other metabolic causes of hyperammonemia that may present with metabolic acidosis instead, like the case for organic acids. Now, metabolic acidosis is another frequent finding. Here, the determination of the anion gap will help us to distinguish between the different causes. Whenever most metabolic causes are followed by a high anion gap. So this will help us to rule out, maybe just to take into consideration that hypoxia is a frequent cause of metabolic acidosis, and it is followed by the elevation of lactic acids, but without ketosis, and that will help us to establish hypoxia as the main cause for metabolic acidosis. And lastly, we have hypoglycemia, to which the normal metabolic response will be to try to start the fatty acid oxidation in order to generate an alternative source of energy whenever we have hypoglycemia. So if we find a hypoglycemia follow without the incrementation of ketones, then we should expect that there is something wrong with the production of ketones. And here we can get the clue that maybe we are facing a fatty acid oxidation disorder. And also hyperinsulinism are related with hypoglycemia with no ketosis, as insulin does repress the fatty acid oxidation as well. But all the other causes of hypoglycemia that are not affecting the production of ketones then should be followed by ketosis. Also, depending on the time that from fasting that hypoglycemia takes to develop, we can have some insights or some clues about the probably etiology for the disorder. And here, for example, if we develop hypoglycemia after a short fasting, we can start to think about hyperinsulinism. And if the hypoglycemia develops from an intermediate fasting, then we may suspect from glucogenosis or gluconeogenesis disorders. And those that rise from a prolonged fasting then will make us think about fatty acid oxidation defects. And whenever we are suspecting and we have a better clue about what are the type of disorders we're facing, there are some other biochemical testings more directed to discriminate between all the different metabolic disorders. Like some commonly used are plasma amino acids, the profile of plasma acylcarnitines, and also the determination of organic acids in urine. And there are some other some frequent laboratory testings that are performed mainly in specialized centers, also to approach these disorders. And all the previous slides are very helpful for the approach of complex molecule metabolic disorders involving intermediary metabolites and those related with energy production. But whenever we are facing complex molecule disorders, these laboratory testings won't be so informative. Here in the routinary testings, we will find some very ambiguous and non-specific findings, more related with the organ dysfunction, like maybe the rise of the liver enzymes or some alterations in the lipid profiles. So whenever we want to diagnose these disorders, we have to have a very, very high suspicious level. Now we can implement some biomarkers, but we have the drawback that many of these biomarkers are not very specific, and many of them have low specificity or sensitivity. So the diagnostics will mainly remain in the determination of the enzymatic activity or the molecular analysis for these disorders, with just maybe the exception of new biomarkers that have been developed and that are very highly sensitive and highly specific and also have some diagnostic utility. And now that the treatment have been implemented for many of these, especially lysosomal storage disorders, there are some additional drawbacks from the genetic molecular approach or the enzymatic activity approach, as they usually do not correlate well with the actual severity of the disease that the patients do manifest. And you can see the picture in the right of your screen of 4 different individuals with who are homozygous for the same variant, and it's clearly they have a different expression and of the manifestations. And also they do not give us the opportunity to follow up with the treatment and how efficient has been the intervention, or how the disease is progressing. So that's why new biomarkers are being developed. And I want to put as an example lyso-Gb1, which is currently the most sensitive and specific biomarker for Gaucher disease. And it has a diagnostic utility as it led us to distinguish between affected individuals, carrier, and those healthy individuals. Also, levels of lyso-Gb1 correlate with the disease burden. As you can see in the graph, increased levels of lyso-Gb1 correlated with low platelet counts in patients with Gaucher disease. And also they give the opportunity to follow the treatment and to see how efficient the therapeutic intervention are being performed. And as you can see in this graphing tables of those patients who were naive for treatment, after receiving replacement therapy, levels of lyso-Gb1 dropped drastically, and they correlated also with some endpoints used to evaluate the effectiveness of treatment, like the platelet count of the spleen size. So now, when to request a diagnostic test for an inherited metabolic disorder. well, they will be indicated whenever we suspect for a metabolic disorder, whenever we are facing a complex phenotype with overlapping symptoms, or who has a broad differential diagnosis. In any case that we face a metabolic crisis in a patient, or when we receive some newborn screening, abnormal newborn screening results, and to those patients that are admitted to neonatal intensive care unit, especially if we don't have a clear cause of what's causing the deterioration in this patient. And now that we are suspecting from these disorders, now we have to take the decision of how to approach them and what technique or study to perform. And this will depend of the experience in the center and also on the certainty of the clinical suspicious. We in Centogene developed two diagnostic tools to approach these disorders, which is one is CentoMetabolic that combines genetic and biochemical testing. This is based in next generation sequencing of 206 genes, including all the coding regions and the interim boundaries, and also those already described intronic mutations for the relevant for a disorder. And the copy number variant analysis through next generation sequencing have been recently implemented for this panel. And importantly, to take into consideration that also some additional biochemical testing are performed, like biomarker and enzymatic analysis. Now, this is the list of genes included in this panel. And now it had been upgraded from a previous version, and now it does includes more possible causes for metabolic disorders. And those categories that implemented maybe the major changes are like the addition of some common organic acid metabolism disorders, and also some fatty acid oxidation or mitochondrial disorders that are now being implemented. And well, you can search for the information related with all the enzymes included in the panel and the biomarkers, but they mostly they have a good coverage for those lysosomal storage disorders. In this diagram, you can see how it's the workflow follow for the CentoMetabolic test. So whenever we receive the sample, it goes through sequencing. Then when after the bioinformatic analysis, those variants of low quality will be confirmed by Sanger. And whenever we find a relevant variant for a gene to which we have a biomarker or an enzyme available, we will perform that test. And all these results will be integrated in the final report. Now, importantly to mention that currently there are more than 50 different biomarkers in development, and they will automatically be added to the panel as soon as they are validated. And the other strategy is CentoIEM, which is more comprehensive in the number of genes that it covers. It includes 491 different genes, now including metabolic disorders, but also some important differential disorders that may be having a very similar clinical picture especially in the neonatal period. And well, this also includes the CMV analysis. And we can see here the different categories included. And if we pay close attention, we notice that it does have a better coverage, especially for those not so common organic acid metabolism disorders. And also it does have a good coverage for those disorders involved with the energy production. And as you notice, there are also some relevant differential diagnosis of genetic cause included, like, for example, some monogenic epilepsies or some familiar hyperinsulinism. Now, when should we decide between CentoMetabolic and CentoIEM? So I will say that whenever we are looking for a cost-effective solution, then CentoMetabolic will be probably the best option. And it also does include all the genetic causes for congenital adrenal hyperplasia, so it should be considered in this scenario. Also, it does have a great coverage for porphyrias and hemetabolism disorder, or those hereditary dyslipidemias. And it's definitely the option to go whenever we are suspecting from lysosomal storage disorders. And CentoIEM is a great solution whenever we are facing, especially those disorders with mainly neurological manifestations, and taking into account that it does also outline or rule out some important genetic metabolic some other genetic causes for some clinical, similarly clinical presentations. And whenever also we are addressing those disorders involved in the energy production, like the mitochondrial or those involving fatty acid oxidation disorders, etc. Now getting into the case studies, this first case is about a male at 10 months old with the clinical suspicious of Niemann-Pick, who after we performed the genetic test, we found some heterogeneous variants in SMPD1 gene, which is related with Niemann-Pick types A and B, but these variants were not previously reported. And the in silico predictions were inconsistent, so we remained with the classification of variant of unknown significance. But after we performed the biomarker and enzymatic test and the level of these enzymes were found to be pathogenic, we were able to reclassify this variant as likely pathogenic. So this is one example of how important this additional complementary testing may be, especially for the classification of those variants of unknown significance. Now we have another case of a female who is 1 year old and is have the family history of consanguineous parents. And well, she presented with motor delay, delayed speech, developmental regression, hypotonia, blindness, seizures, and hypodontia, and also had an affected brother with a similar clinical presentation. And after we performed the enzymatic and genetic test, we discovered that the patients were also having a dual diagnosis, which is a scenario that is not that rare for genetic disorders. Now, by the data obtained by exome and genome analysis, we know that about 5% of all patients suffering from a genetic disorder actually have dual diagnosis. So this is one advantage of taking a broad approach. This is another case for a patient 6-year-old that have recurrent airway infections, short stature, hepatosplenomegaly, dysostosis multiplex, and intellectual deficit, and coarse facial features. And if you may suspect, well, this is a very characteristic clinical picture for mucopolysaccharidosis, especially for Hunter and Horler syndromes. And in this case, the physician was suspecting from a Hunter syndrome, so requested a CentoMetabolic, and the result was negative. But due to the high clinical suspicious, they requested the enzymatic testing, especially for iduronate 2-sulfatase, which we found to be at pathological levels. So the diagnosis of Hunter was performed. So, and what happened here? Well, especially EDS gene is followed by a Centogene, by a pseudogene, which gives rise to complex rearrangements that will be not detectable by sequencing. So there should be implemented a specific assay trying to search specific for this variant. And after we performed such test, we find out that this was the causative of this disorder. So this happened because like the workflow for CentoMetabolic follows that after we find a relevant variant, then the biochemical analysis is performed. So in this case, that was one of the limitations due to the workflow currently available for CentoMetabolic. Here we have a male patient, 2 years old, who have neonatal icterus, vomiting, and enlarged liver and spleen, and also developmental delay. So the diagnosis of Niemann-Pick was suspected, and when we have a high suspicious of one disorder, what test should we perform? So here the physician decided to perform biomarker testing because he was suspecting from this to be related to Niemann-Pick. But after we performed that test, we came out that the results were negative, which rule out the diagnosis. So then the patient followed with deterioration, and after the evaluation, also the sequencing for other genes suspected, they finally came out with the request for CentoMetabolic, and well, the diagnosis of galactosemia was discovered, and the results were immediately reported to the treating physician. Now, just to close the presentation, Just remember that CentoMetabolic is empowered by CentoMD, which is a very extensive database for variants related with rare disorders, and it includes samples for almost all over the world. And as a summary, remember that many inherited metabolic disorders do have effective treatment, and that's why we cannot miss them from the diagnosis. And that the earlier we implement diagnosis and an adequate treatment, then the better chances we have to prevent handicap or even death. And we should suspect these disorders in parallel in other conditions in those critically ill childs. And finally, that CentoMetabolic does combine the genetic and the biochemical testing, and that CentoIEM does include a broader approach for metabolic diseases and also for their main differential diagnosis. So that will be it.
Many thanks, Carlos, for sharing your knowledge with us. And let us now move on the question and answer part of the webinar. As we have already received several questions from our participants, let's start with the first one. What they are asking is, what is the utility of performing additional biochemical tests if the molecular testing was already performed?
Well, for this question, I give a clinical case that may be helpful to get this picture clear. Biochemical analysis may give us some additional information about the disorders, and also they are especially useful whenever we have found a variant of unknown significance. So that may be probably the two better examples of why they are important. Also, they may give some information about the burden of the disease and may help to correlate with the severity of the disorder, or may give us a baseline after we to which compare the efficiency of a treatment that may be implemented in some of these disorders.
Okay, another question is, which biomarkers are included in CentoMetabolic panels?
Well, you can go to the description page of the product to have a better and more comprehensive revision of this. But mainly, right now, there are some high specific biomarkers included that are lyso-Gb1, lyso-Gb3, C26 acylceramide, 3-O-methyl orthomethyl dopa, and I don't remember the last one. But yeah, those are mainly the ones included. But yes, I will recall to try to go to the product description to have a better and a more comprehensive review of this. Now, also to take the opportunity to remember that there are more than 50 biomarkers in development, and that they will be automatically implemented to the panel. Now, there is another question, which is saying why we have a high suspicious for a disease require before performing the testing, we should require a high suspicious and disease related with complex molecules. And it's asking if we can perform screening for this kind of disorders. Now, yes, there are some screening programs related to complex molecule disorders. But what I was mentioning is that whenever we want to perform the diagnosis for these disorders, the biomarkers available are usually directed especially for these disorders, and that's why we have to have a high suspicious before to perform the test, because the routinary, we won't find them in routinary laboratory testing as maybe we can do with other more frequent everyday use laboratory tests, like the glucose levels or the pH determination. That's why we mentioned about this suspicious required. Now they are asking if dry blood spot samples were used for the biochemical analysis. And here is yes, dry blood spots are maybe used for biochemical analysis, and Centogene has now implemented and validated their assays and processes in order to have the biggest precision possible after performing tests from this type of samples. And I think we are just about time.
Carlos, one more time, thank you for sharing with us your insights, and thank you to all of you for participating and joining our case study webinar.